Hello, everyone, and welcome to McGill Cares webcast series supporting family and informal caregivers. I'm Claire Webster, a former caregiver, certified dementia care consultant, and founder of McGill University's Dementia Education Program. These webcasts are made possible thanks to the generosity of donors, and today's webcast is thanks to the Zeller Family Foundation. I work with a dynamic team of leading healthcare professionals to lead this program, who include Dr. José Moret from the Division of Geriatric Medicine, and my very special guest today, Dr. Serge Gauthier, the former director of the McGill University Research Centre for Studies in Aging, and Professor Emeritus, who is leading the departments of Neurology and Neurosurgery, Psychiatry, and Medicine at McGill University. Dr. Gauthier is leading the initiative to produce the World Alzheimer's Reports, one that was just released in September of 2021 on the topics of diagnosis, and is also leading the 2022 World Report on the post-diagnostic support. Dr. Gauthier was appointed to the Order of Canada in 2014 and the Ordre National du Québec in 2017 in recognition of his contributions to advancing our understanding of Alzheimer's disease and dementia, and for fostering the development of research networks. Welcome, Dr. Gauthier, to McGill Cares.
Merci.
Dr. Gauthier today is going to be providing us with an update on the pharmacological management of dementia. That is, what the role of medication, the role that medication plays in treating dementia. So before we get into Dr. Gauthier's presentation, I have two very important questions for you. First and foremost, why has it been so difficult to find a cure for dementia?
Well, a cure is a difficult word to use because it would mean disappearance of all symptoms for everyone. We're not there yet, but we do have, as I will explain, we had a lucky break for some medications to help symptoms, and we're close to having some medications to control some of the basic changes in the brain that are associated with dementia.
But can you explain what makes this illness so unique that it's just been so difficult to find really like a cure, a treatment, medication to stop its progression? I mean, look at the advances that have been made over the years with regards to cancer or other illnesses. Like, what makes dementia so unique?
Yep, the good comparator. We consider the field of dementia about 40 years behind the field of oncology, but we're going to follow that model from now on, as I will explain later. What makes the field of dementia complex is there's more than one cause. And even in a disease that everybody knows more about, Alzheimer's disease, there's more than one underlying factor at play. And we know that some people have more than one factor than another at play. So we're moving to a personalized approach to diagnosis and treatment.
Okay. So in your presentation, you're going to be using, there's two terms that keep coming up over and over again that are difficult for lay people like myself to understand. And the two words are tau and beta amyloid. Can you explain what those words mean?
Yes, indeed. So these are two proteins associated with brain aging. We all have some deposits of beta amyloid, a fragment of a larger protein. Some people have it earlier in life, like 30, 40-year-old, because they have inherited a gene that interferes with the breakdown of that big protein, and they have too much of the beta 42. Most people over age 80 have some accumulation of beta amyloid 42 protein, but it doesn't bother most of them. There's some other factors at play. Namely tau. Tau is the name of a protein within nerve cells that is important to maintain the structure within the nerve cell and to help carry nutrients and neurotransmitters from the cell body to the synapse. And in Alzheimer's disease and some conditions called tauopathies, there's a change in the structure of the tau protein. It sort of twists on itself. En français, it's écheveau. In English, it's a neurofibrillary tangle. And you see that with the microscope. But again, most people over age 90 have both of these proteins building up in their brain and have no symptoms. So there's a third factor or a fourth factor, which we'll discuss today. So thank you, Claire, for the invitation. I've prepared some slides to go over the topic as a whole, an overview, and then I'll answer your questions on behalf of the audience. So next slide. When you talk about medications, you have to declare potential conflicts of interest because I do provide scientific advice to various companies that work with medications. I don't think it's relevant for the topic today, but you always show that. Next slide, please. So a reminder before we talk about medications that it's only one part of the global management of dementia. So diagnosis comes first. This is what we worked on together for the first world report that came out in September. Education about the disease is something we're doing at McGill very well with the Division of Geriatric Medicine and the Center on Aging. Prescription for care is a term you created, Claire, that will be the main topic of this year's world report. Now, for today, I must say that we have medications to give people with dementia first for concomitant diseases. They have other things than dementia, especially over age 80. So people will be on medications for the bladder or the heart, and some of them may interfere with memory in some way. So that's one thing to think about when you talk about dementia and drugs. And the last line is drug specific for symptoms of dementia and the new ones that are coming. Next slide. First, concomitant diseases. So there are common conditions in older people that have dementia, such as atrial fibrillation or irregular heartbeat that usually requires a blood thinner, high blood pressure. But you should be careful not to overtreat high blood pressure when you're over age 80, because low blood pressure can be actually more harmful than high blood pressure. Diabetes type 2, very common, that needs to be managed very well. High cholesterol is less of an issue over age 85 than it is in midlife. What's new is vision and audition. So that's not drug related, but it's a common comorbidity. You have to help people with their vision and their hearing so they can remember things. Depression can be very often associated with early stages of dementia when people still have insight. So I'll mention that as one drug we use early in the course of dementia. Sleep apnea is very common and needs to be treated, and prevention of falls is a major issue that Dr. Moret will talk about, or has already discussed with you at McGill Care. So next one is the medications. So first, medications for symptoms associated with dementia. So the lucky break we had about 20 years ago was a discovery that with Alzheimer's disease and related conditions such as Parkinson dementia, Lewy body dementia, there is a reduction in the brain of one neurotransmitter called acetylcholine. And the first line of on the diagram here is the cholinesterase inhibitors. It's a class of drug that makes the acetylcholine in your brain last longer when it's used. It works in about half of the patients who take it. It's not so much memory as much as attention, paying attention, some retention, and an effect on awareness and interest in doing things they gave up on. So 3 medications, donepezil, rivastigmine, galantamine. The advantage of 3 of that class is you can find one that agrees with you better, because as a group, they can slow down a bit your heart rate. They can cause a bit of nausea as you increase the dose. And you may find one agrees with you more than another. There's a second class, the second line called memantine as the one drug from that class. This medication works on a different transmitter system in the brain than acetylcholine. It works on glutamate receptors, and it seems to suppress the excessive activity of that type of transmitter. And this medication works best in the moderate stage of dementia. It seems to reduce a bit of the agitation that sometimes is associated with that stage of dementia. Third line antidepressants, they're commonly used early in the course of disease when people are still aware of what's happening and they worry about the future. But they're also tried in moderate to severe stages of dementia when there's agitation, which may be in part due to masked depression. And the Last line is antipsychotics. These are medications used primarily in schizophrenia, but sometimes they're required also for some of the symptoms associated with dementia. The best known is risperidone. In very low dose, it's used usually for 3 months, sometimes 6 months, for aggressivity that is not responsive to other non-pharmacologic approaches. So as you see, quite a few medications for symptoms. So already, these are standard prescription medications available to all doctors. Next slide. Now, if you put these medication class across the spectrum of the course of a disease like Alzheimer's disease, you have in mild cognitive impairment, the second step. These are people with memory complaints or looking for words, but they're still managing their daily routine, no dementia. There's no standard drug at that stage. Once you have early dementia, so your memory complaints, you're looking for your car, you need help a bit to pay your bills, yes, you should start a cholinesterase inhibitor, donepezil, rivastigmine, galantamine. You may also need an antidepressant if the fact that you're aware that you have mild dementia is an issue. In moderate stage, that's when you stop driving. You need assistance for choosing what clothes to put on, depending on the weather, that sort of stage. Memantine is often substituted for the cholinesterase inhibitors. And in moderate to severe, this is close now to needing to move to a long-term care facility. There may be agitation, especially at night, that requires a bit of a sedative antidepressant or an antipsychotic low dose. And in the severe and terminal stages of dementia, usually there's no specific medication. Next slide. Now, talking about the new medications. For this, we need to broaden the discussion to before dementia. There's 3 to 5 years of symptoms before dementia. This is a stage now called mild cognitive impairment or prodromal Alzheimer's disease. And this is maybe the time where we can modify the progression with medications I will now talk about. Next slide, please. Yeah, so these are the main pathological features underlying Alzheimer's disease. You have on the very left beta amyloid deposition. That's the protein you were inquiring about. Mm-hmm. Yes, so more specifically beta 42, so 42 amino acid long. It's between the nerve cells, it's floating around, and it clumps into plaques that you can see with a microscope, and now that you can see with the PET scan. In the middle, you have the neurofibrillary tangles. So that's the tau protein you were asking about. So you see here in black, the nerve cells that are colored with a stain that brings out these neurofibrillary tangles. And we all have some of them in our medial temporal lobe. So that's why when we get over 70, there's a hesitation for, what's the name of that person again? Okay, that's normal. But if the tau protein spread to the surface of the brain, the neocortex, that's not normal. And one of the treatments we hope to find soon is how to prevent the spreading of the tau pathology in the brain. Notice before tau neurofibrillary tangle blocks, there's microglial activation. So that's a neuroinflammatory component of the pathology that we know is present, but we're not sure when exactly in the timing of the course of Alzheimer. And if we could catch the inflammation at the right time, we could perhaps suppress that accelerated nerve cell loss phase of the disease. And finally, you see neuronal loss, so the brain is getting a little smaller. We see that with the MRI, and then you get symptoms. So you see there's a big time frame, 10 to 20 years before you get symptoms where we could intervene. So the next slide, some options for treatment. So beta amyloid deposition, and there are drugs to do that now. Tau hyperphosphorylation, can we prevent the tau protein from clumping into tangles? And the brain inflammation, as I was mentioning, if we catch it at the right time, can we suppress that inflammation phase of the disease? Next slide. Most of the focus of the past 10 years, excuse me, has been on beta amyloid deposition. And you see here illustrated various ways to go about it. You can decrease the production of the beta amyloid. You can increase its clearance. You can break it down with immunotherapy. the so-called vaccine approach. And this is where we have our first successful therapy against amyloid, as I will illustrate now. Next slide. So this is the result from a phase 3 study that was conducted around the world with a drug called aducanumab. So that's the word listed on the title here, aducanumab. It's a word that you may have read about in the papers because it was recently approved in the United States by the Food and Drug Administration. What you see here is the measure of the amyloid buildup in the brain before and after treatment. And you see the horizontal line at the top. These are people who got a placebo. They got an injection of water. The blue line at the bottom are people who got the high dose of the antibody against amyloid. So this is an IV infusion once a month over a year and a half. The antibody gets into the brain, not a lot of it, maybe 3% of what you inject in the vein gets into the brain, but it's sufficient, as you see here with the blue line, to completely normalize the amyloid buildup after a year and a half. Now, does that change something in the patient course of disease? Next slide, please. So you see here what happens to the patients over the year and a half using a questionnaire that's called the Clinical Dementia Rating Scale. It's a questionnaire you do with the patient and the accompanying person. There are 6 sort of topics: memory, orientation, community affairs, self-care. So you add up the 6 boxes or items and you get a score. And what you see here over the 78 weeks of treatment, the first line in gray is the natural decline over time. It's not a lot. These are people with mild cognitive impairment mostly, so not yet dementia. So it's a slow progression. But you see in blue a reduction of the progression for those who got the high dose of the drug. It's not a big effect, but it's statistically significant. What's more impressive is the next slide, please, Claire, where here you have a breakdown of the various aspects of the life of these people over the year and a half. So you have on the very left what we just looked at, the total score on the 6 items, but then you have the mini mental state, which everybody knows. It's a routine test done at the diagnostic and every visit. Then ADAS-Cog is a more complex memory test done usually only in research. But then you have ADL, Alzheimer's Disease Cooperative Study, ADL. This is a questionnaire usually done with the family member about whether the person can do certain tasks at home, including deciding what to wear, how to use their money, how to use appliances. And you see minus 40, it's a reduction of the progression of the disease. And to me, what's most impressive is the very right, where you have a checklist of 10 questions about the behavior and the mood of that person. And you have a reduction of 87% in the progression for those at the high dose of the antibody. So you have less emergence over a year and a half of depression, anxiety, aggression, aberrant motor behavior. This is very meaningful, I think, for the family and for the person. The problem is that study that was so positive was done at the same time as another one with the same antibody, which showed nearly nothing of that. It's like complete absence of response. So the debate is whether that one successful study was sufficient to approve the drug or whether you need a third one, which will be somewhere in between perhaps in the results.
But Dr. Gauthier, just to clarify this, because so this is really interesting, and just I know for the audience too, because the chart could be a little bit confusing. So for example, when my mother started showing symptoms and I went, the first appointment that we had with the neurologist, she scored 17 out of 30 on the MoCA test. Now she was prescribed Aricept, okay?
Yeah, donepezil.
So
Wait.
at what point though, like, can you just like, so I know the stage that she was in at that point, right? Like she was still, you know, could still have conversations, but it was clear she wasn't able to manage her finances. It was clear that she was in, you know, she was not able to recognize her own symptoms. But at what point do the drugs no longer work? Like at what point does the person no longer cannot qualify for this drug?
Well, certainly your mother would not have qualified for this particular study here, nor for the treatment if it's approved. This is for people with mild cognitive impairment. So just before dementia. So your mother
Okay,
would
just
not have
before.
been offered this particular treatment, but there are others coming up against tau that would be applicable for your mother. And the
Okay.
results of the anti-tau therapies will be available next summer.
Okay.
So this allows us to talk about disease-specific and stage-specific treatments like we do for cancer. You're quite right. We're nearly done with the slide. The last one, indeed. So you remember the previous one with the symptom? So here we're just adding amyloid therapy for mild cognitive impairment. If we have a third study to confirm what we just discussed, and there are other drugs like aducanumab being tested now around the world. So it's a class that will stay, but it will be only for that very early stage of disease for people who do have amyloid in their brain. And let's be clear, it's not everyone with Alzheimer's disease, even at the mild cognitive impairment stage, that has amyloid in their brain. Maybe 20% don't have any. It's another kind of Alzheimer. It's mostly tau. So that's why we need to work on anti-tau therapies. And for now, I put tau therapies more at the moderate stage, like your mother. But for those who have the amyloid negative kind of Alzheimer at the MCI stage, maybe the anti-tau therapy will be offered earlier. So it's getting more complicated, but more exciting. I think within 3 years, we'll have 2 treatment options for those at the very mild stage of mild cognitive impairment, anti-amyloid and anti-tau. And those who have already mild to moderate dementia, they will go straight to anti-tau therapies.
So Dr. Gauthier, thank you for showing us your slides. And I've collected some questions that people ask, just to see if you can clarify some of these answers. So for example, the people that qualify or would be able to be prescribed a drug such as Aricept, okay? How much time does it give them in terms of preserving their memory? I mean, are we talking years? Are we talking months? Like, how much time does it give them? Like, how does it slow the progression of the illness?
Okay, so this is the old class of drug now. We call them the first generation. They work on acetylcholine buildup in the brain. They don't modify the disease progression, but they modify the symptoms progression. And you can think in terms of 2 years of relative stability if you start early. If you start in the moderate stage, like you would have done with your mother, you may gain 6 to 12 months of relative stability for the symptoms. And that's meaningful at that stage because it may mean an extra year at home.
So then at what point does a doctor like yourself decide, so for somebody who's on this medication, it's time to stop because it will no longer help? Like, what does that stage look like?
So that's a very important question that has been addressed by various bodies in Canada. The deprescription is the term we use. It's usually at the severe stage of dementia, when you're usually not able to feed yourself. You're probably not walking very much unless you have help. It's the stage where you start thinking of what's the best quality of life for the remaining year, the year where you will get an aspiration pneumonia or you will fall and break a leg and get complications thereof. So it's not just donepezil that you would consider stopping, it's all medications.
Okay. So at the beginning of your presentation, you talked about, you called them concomitants or comorbidities. And what that means is many people have other health conditions. As you mentioned, heart conditions, they could have diabetes, they can have high blood pressure. So how does like those, because they're all existing medications. So how does these other pills, how could it interfere with the other medications that they're on? Like, what are the side effects?
The main one that we worry about is the medications used for bladder control. Some medications, there is a class called anticholinergic. They do the opposite of donepezil, but they may help your bladder relax, so you don't need to go to the bathroom 10 times. You go only 5 times. So that's a class of drug that we systematically try to stop if it's possible. Sometimes you take medicines for heartburns, and they may also interfere to some degree with your memory. If you overtreat hypertension, that could be harmful. I mentioned that low blood pressure can be harmful in people over age 85. So people, I think, expect that if you take 3 pills for blood pressure between ages of 65 to 80, expect a reduction of those pills, as you don't want to have a blood pressure too low anymore.
So you also mentioned that some of the medications that people are on may be causing some memory issues. It could result in. I mean, could you explain that a little bit, because you mentioned at the beginning of the presentation?
I mentioned mostly the bladder pills, so-called, but you're right. There are so-called anxiety medicines like benzodiazepines. Ativan is the best known, lorazepam, but there are others like that. So benzodiazepine as a class are completely now avoided over age 80 because they have lasting confusion effects and they could increase the risk of falls.
Okay. And another important question is alcohol. So people are taking all kinds of medications, and now you may be introducing them, one of the other medications that you described. Can people drink with these medications? Can they not drink? And if they can drink, how much is acceptable?
You know that we recommend 1 glass of wine a day to prevent brain aging. So yeah, that should stay. The issue about alcohol, it depends what pills you take. Some of them, they're metabolized by the liver, and too much alcohol can interfere with that metabolism. The pharmacist would advise you if there's concern. The medications we talked about today, there's no specific interaction with alcohol. So you can continue your glass of wine regularly, no problem.
And what about hard alcohol? Because I hear about a lot of people, continuing to drink whiskey, continuing to drink vodka. Like, is it better to stick to wine than mixing it with vodka or other hard alcohol?
Well, the wine is the kind of alcohol that's been linked to prevention when it's used in moderation, which is 1 glass a day, to make sure it's a good wine if it's only 1 glass.
Mm-hmm.
I don't know of any new information about hard liquor, as you mentioned, but it should be, again, used in moderation, probably 1 glass a day before your evening meal. It may help your appetite, which is a good thing, and it may prevent the use of anxiety medicines, which are usually not good.
What does the role of certain vitamins play in this, like B12, for example? I mean, if people are taking all of these medications, how do you feel about the supplements?
So B12, thank you for mentioning B12, because it's a common deficiency, and we always look for B12 deficiency when we do the diagnostic workup of someone with early dementia. And that usually is caused by a malabsorption of the B12 that you ingest. It's not absorbed through your stomach and bowel properly, so you get an injection instead. More recently, it's been found that if you take extra doses of B12, you don't need the injection after all. So B12 supplements only if you have a deficiency. Vitamin D is something we all need because of the sun exposure, and we need to prevent osteoporosis. There's no need for other vitamins unless you have a deficiency.
And then you also mentioned excessive brain inflammation. I mean, are there certain causes of brain inflammation, and what could we do to prevent brain inflammation?
Oh, that's a big topic, Claire. There is a normal amount of brain inflammation. It helps clear away breakdown products, waste products from cells. So there is a normal amount. It's also there to help fight infections, virus that get into our brain. So you don't want to suppress all inflammatory responses in the brain. So that's one issue. Beta-amyloid, the original protein, was thought to be an anti-infectious protein way back when we were mammals. And it's probably better not to take away all the amyloid in the brain also. That's been an issue with some of the experimental drugs against amyloid. There was too much of a reduction, and then you were causing unexpected side effects. There are anti-inflammatory drugs used for arthritis and related conditions. They were tested already in people with mild cognitive impairment and with early dementia with no benefit compared to placebo. That's been done. But what was missing is the people who got enrolled in those studies, we didn't know their inflammatory status in their brain. Now we can do that. We have new PET scans and spinal fluid examination that could allow to find people who are actively having inflammation. Then they could get randomized to a medication for arthritis or to placebo and see if it makes a difference. There's still hope that if we can find out who has active inflammation and it's relevant to their disease, we could intervene with existing drugs.
I feel like today's webcast is a really important message about, having a regular assessment by the family physician or the neurologist or the geriatrician, because it sounds like, when you're taking this much medication, it's a constant adaptation, correct? Like, if a medication isn't working, the doctor may be able to prescribe something else. I mean, it's important to be closely monitored by your doctor to manage all of these medications, because one of the questions that people have is, well, what if this pill isn't working? It doesn't make me feel well. I mean, I'm assuming that you can offer different alternatives.
So for the existing symptomatic drugs, you're quite right. Usually the visits are every 6 months with the specialist or the family doctor who has a special interest. The new medications we are talking about, infusions intravenously, this is going to be a whole different strategy for monitoring. Probably it will require specialty monitoring for the first year of treatment and then once a year follow-up visits. That's still being worked out. But back to reality right now, indeed, you need to have a regular follow-up at least once every 6 months with your family doctor or specialist.
Dr. Gauthier, thank you so much for taking the time with me today. I mean, there's so much information, difficult to get it all in one webcast, but I greatly appreciate you taking the time to be with us today.
It's a pleasure. And of course, the audience is welcome to send us emails, questions by emails. We'll be glad to answer.
Oh, thank you so much. And just want to let everyone know that this webcast is an initiative of the McGill Dementia Education Program, which is funded by private donations. I would like to sincerely thank the Zeller Family Foundation for supporting today's webcast. If you would like to make a contribution to our program or for more information, please visit us at mcgill.ca/dementia. And as Dr. Gauthier mentioned, if you have some questions and you would like to write to us, please email us at dementia@mcgill.ca. Thank you for watching.